Dr. Daly, you are live.
We are. Excellent.
What I could say is I'm only bringing 2 dozen. Then
You
you would get your
All right. If everybody's ready to go and everybody is appropriately plied with cookies, let's get started. Thanks for coming today. I appreciate it. Sam's going to go back. I told you to get more, Sam. Would somebody please pass the box around? So, has everyone had a chance to review the April minutes, and are there any corrections? Excuse me, the May minutes. Any corrections? May I have a motion for approval, please? Thank you. Seconded? Excellent. All in favor? Thank you. Before we begin correspondence, I'd like to welcome Kevin Collins. He is one of our second-year residents, becoming a third-year resident. He's been active in EMS in the region for 10 years, 15 years? 13. A long time. Not as long as Alfred, but a long time. And he will be joining us from time to time from here on out. So welcome, Kevin. As we move forward, we have excused Dr. McHugh, and Dr. Duthaler did attempt to call in. Unfortunately, we're unable to do the teleconference today because of technical concerns. Let's start with committee reports, please. Don.
Okay, academic, a whole bunch of courses that are starting up. There's a list if anybody wants to see them. There was a discussion on the new AEMP, which is the old intermediate standard, of which the question came up. We have no protocols for these folks as of yet. So there is a subcommittee of the committee that's going to meet, including Rich Scott, during the summer and try and come up with some new suggestions for new protocols for their new classification. That's the best way to put it. There was another question that was brought up to me after the meeting that actually needs to be brought up to this group. So I'll throw it out there. The use of ACLS and PALS as CME for your CME requirements per year for Remac. In other words, can you use a ACLS card, which would be somewhere around 12 hours worth of CME if you broke it down, or PALS the same, which if you did both of those would be your total CME for the year. Or since that's a requirement that they have to have an ACLS or PALS card, then not be used. And Dean, looking back through what we've done in the past, for a while we said no, then we said yes, and we sort of said no again. It's been this group that's made that decision. So now it's kind of in this quagmire where some agencies are feeling that they shouldn't be doing that because the intent is, did you actually get education over the year? That is not something that's a core requirement. And one other clarification. So I need to bring it up to the positions because that's who voted on before. Do we let them use ACLS and PALS and let them use those cards every 3 years, 2 years actually, to end up using their CME, or do we say no, you're required to have these cards, in which case you need to have CME, which is the intent of having CME?
Well, a card's not a class, right?
No, but they'd have to go to the class and they'd have to have a...
But I'm saying you can achieve a card without going to a class, essentially.
Right.
This is going off foreshortened class, virtual class.
This
you
would
get a research card.
Right, it wouldn't be for people who will be essentially researching because we're not going to be anywhere near as many hours, so I guess you could break it down.
Well, you could still take it for a class if you desire.
Right.
Most people don't do that. So the registry says what? You have to show paramedic refresher training every 2 years or equivalent hours, correct? I'm using that as a corollary example.
Well, I think the example that you're starting with, John,
I
was
can't
exactly right.
as a paramedic and show that to the registry for 48 hours of credit. Right. Right. I have to give you class time of some sort. So, is that a parallel kind of example?
Well, it doesn't count. It wouldn't count as 8, 12, or 16 hours for state CME, right?
No, that is not correct. It will count. You can use ACLS, PALS, any of the alphabet courses, the PHDLS, analysts. You can use all of that towards your CME full courses. Even the partial courses you can put towards the other if you're not using it for the core. But my point you have to make a choice whether you want them to make an additional effort to get more CME, or whether you want them to have, or whether the ACLS and the PALS would cover their CME every year or every 2 years. So that's just, I think we're looking for some consistency. That's what we're doing.
New York State for the core content will allow you to take all the alphabet soup classes and break them down into these respective hours, just for some similarities.
So that's what we brought here. Where do we want to go with it?
Well, they give you 1-for-1 on the hours, right?
Yeah.
So if you take a 2-hour research, it's 2 hours.
Right.
It's not 12 hours.
Right.
Right.
Exactly.
Correct, but Mike, it has been tradition here, and it used to be very, very spelled out, so all I want to do is make sure I understand what the rules are. Can you have not been allowed in the past to use ACLS, a pediatric card, or CPR for any part of your turnaround document.
Or Remac.
That's the turnaround document, that's Remac. All right, so is that changed now? Was there any discussion on the change? Do you want to use it? I just want to know what your intent is, so that you can do the right thing.
Yeah.
It was, well, actually, it was a different circumstance, and somebody else needed it. It really wasn't us causing the problem. Didn't know whether to say yes or no about this circumstance. And it was clear cut that Remo didn't have a real policy on it.
From agency perspectives, and there aren't that many agency reps here right now, and frankly, I would say I'd rather see people get more rather than less. I don't see that the alphabet soup courses, particularly since there's so much variability between the amount of time that they really take, can consistently certify a certain number of hours, regardless of the expectation of the certifying bodies. I'd rather see people do more CME rather than less. But Nash, how's that going to affect you guys in Wilton?
Not that affects us at all. I think it should be an agency decision.
An agency decision. Okay.
Like, I mean, the region says they have to have ACLS and PALS and whatever else the requirements are.
Mhm.
And when the agency submits their letter saying that these individuals are online, signed by the medical director, it's the agency's decision if they want to count that to minimize their hours, or if they want to say, yes, they have cards plus these hours. It should be how they want to manage the people.
Sounds like a job for Brian Taft. Where is
Well,
he?
Yeah, really.
I'm channeling my inner Brian.
I just wanted to be consistent with the number of hours you require.
Which then brings you a really interesting question, because then all of a sudden we have a significant discrepancy between agencies.
Right.
And now you say somebody's been working for you, not counting ACLS, but getting 24 hours, goes to work for somebody else where they count ACLS, that's okay. But if it goes the other way, all of a sudden you've got someone who's gotten 8, 12, 16 hours less training the year before, and potentially consistency. You know,
It sounds like there's a, you're saying tradition versus policy.
No, I'm saying, this is what you have asked us to do in the past. Clarify what you want us to do. Because, I'll be honest with you, from a Mohawk perspective, we require our people not to use ACLS and PALS, and we insist that they do 24 hours of other CME. I don't want them beat up. I don't want them having to do more than the other. So the reality is, I'd just like to understand what your policy is of what you want. That's all I really want out of this.
Rich?
The whole CME issue is a kind of a red, in terms of recertification, and separate topic. As I remember, historically, the region has always maintained a position that there would be education to improve the quality of care, and that basically it fell down to 2 levels. You had competency assurance, which meant that everybody had to have ACLS and PALS, period. And then there had to be a certain amount of professional development done annually in order to increase the quality of care. And really, that falls in line with the federal documents on QI. That'd be 2 levels: competency assurance, aka ACLS and PALS, and then professional development should be additional hours. What is always flexed around here is how many additional hours have been. Some years we had 12, some we had 24. That always seemed to be in flux. But the constant always was ACLS, and then we added a pediatric course, specifically the terminology of pediatric course, including EPC, PALS, and PAP.
Mike, according to the 2012 document published on the Remo website, it breaks it down into 2 distinct categories. It says EMT, CPR, ACLS, PEDS courses are not expired, and there'd be a green check if your certification's in date, red flag indicates certification's expired. And then the next bullet point is ALS and other CMA hours have been completed with 24 hours in parentheses. So the way I would read this as a provider would be, these are two distinct things. I have to keep both my CPR, my EMT, my ACLS, my PED certification, in addition to doing 24 hours of certification. At least that's the way I read this document.
I agree, and that's the way we've
That's
been
the way I
reading.
think about it. But
Clearly, that's not the way it's been done other places, and it could be interpreted the other way. I'm trying to be fair. And it just, but let's clarify what you want, and that's the way I read it too, so. It's more important what you guys want as physicians, what you want the medics to go through and accomplish.
I know what a lot of providers have done in the past is they say, look, I need 4 hours. I already have my card, but I'm going to go to this ACLS class. I'm going to go to this PALS class. I'm going to go to a PEP class because I need pediatrics category filled, but I already have my card, so I'm going to go and take it as a CME even though I already have my card. And I know there's a lot of providers out there doing that, again, taking the alphabet soup courses for additional credit even though they already have their card established because maybe pediatrics isn't available in the time frame they need or whatever the case may be. So I know there's a lot of providers out there doing that, taking those courses just for the CMEs, not for the card itself.
Do we not offer enough pediatric courses?
what? I was going to say, there's actually a pretty decent amount of pediatric coursework available out there, certainly from what I've seen go. And we've actually put together some extra programs over the last couple of years, thanks to some funding from EMSC and the Department of Health. I think it's actually a HRSA grant.
I mean, I hate to
that's helping with
complicate
that.
things even more, but I mean, I would almost like to see, yes, you can use your PALS stuff as credit, but not your ACLS, just because we do ACLS all the time. You don't do you don't use the full extent of your PALS very often. And if they want to take PALS in between, when they don't need certification, I think that's great as a refresher, just because you don't use it so much. But I think that's making things a little too complicated.
I could add something to that.
Go on, make
And
it
I
more
don't want to
complicated.
complicate it.
Go for it.
You can not use one pediatric card. Let's say you take PALS. But if you want to take a PEP or an EPC on top of that, absolutely. Then you can use that towards a CME because that's a continuation, that's furthering, and it's a different point of view. Just a potential that if somebody's scurrying because they need it. But when you take these classes, they are not all equal, clearly. Some are done in a couple of hours, some are done in 12 hours, some are done in 16 hours. So I guess just all you need to make the decision, it boils real simple. Do I want that extra hours, or do I want to make it easier to do the CMEs, or do I want to have the actual education? That's really what it comes down to.
Sounds like we need a motion.
I'd make a motion.
Make a motion.
Make a motion that ACLS and PALS do not count towards your 24 hours of required CME.
Second?
Well, wait a second, before you want to amend that to include what Jeff mentioned, if you want to take an advanced course?
Just ACLS and PALS, yeah, those other advanced courses could count.
Because we don't call them a pediatric, we don't call it a PALS card, they have to have a pediatric card. So if you took EPC, then you could take PALS. If you took PALS, then you could take EPC or PEP or whatever.
ACLS in your primary pediatric
Right.
card?
And how about CPR?
Yeah, that should not count towards your CME.
So you want
Sorry.
to, so how about restating that?
Okay.
I would,
Go ahead, restate it for me.
Okay, unmake that motion.
we don't want to penalize anybody, give them a period of time.
All right.
I hear John Politis saying, you can't stick this to me today and expect me to pay for it. Does that make sense? That was kind of one of the things John used to harp
Or you
on.
can have an implementation.
Yeah, except we already
Have
have
an
people who-
implementation period,
Yeah.
like 6 months or a year. so
Yeah, but they've
nobody-
got 6
Well, no, because that's kind of where we already are,
They're at
so
the
I
same
don't think that's going to be an issue.
I think most people already do this.
Wow.
That's the way I've always interpreted it.
Everybody, I'd like to introduce Norm Chapin.
Doesn't he look like Mr. Smith out of Matrix?
Cheap and reloaded.
Yes.
So since Norm just arrived, Norm gets to make the motion.
I move that. So how are we saying this, Aaron?
So ACLS and your primary pediatric certification and CPR do not count towards your required CME hours.
Okay, that's probably.
How about list the courses that need to be, or the cards that need to be done? These do not count towards your CME hours. So that it.
Apparently some people take something besides PALS as their primary.
Right, but that first section that Mike read there, how's that worded?
So it says EMT, CPR, ACLS, PEDS course are not expired. That's the first bullet point. Second bullet point is ALS and other CME hours have been completed, in parentheses, 24 hours required.
So all certifications for Part 1 do not count towards hours in Part 2?
That's the way it looks. I mean, this is just a bulleted list in terms of.
But any certification used to satisfy Part 1 cannot be counted towards Part 2?
No, it doesn't say that.
It doesn't say that because this document, right? If I'm correct, we used to have the form, but now with the ALS database, they go online and do all the stuff in the database.
Mm-hmm. And do we want to add a time to that? Do you want to start out at 2014, 2015?
I interpret that to mean that you can use those courses toward the 24 hours. That's the way I interpret that. I think it's very ambiguous.
It is.
It is ambiguous. That's why we asked for clarity on it. So
I think it's very ambiguous the way it's written.
Well, Sarah's motion's good, just do we want to put a time frame?
Let's have Sarah repeat her motion. Then let's see if we can get a second on the motion, because we actually shouldn't be talking about the motion until it is seconded.
Checking to see if it's the same each time I repeat it.
Any discussion on the motion before you?
Okay, so the motion is that ACLS, CPR, and your primary pediatric card hours do not count towards your required CME hours for recertification.
Is there a second? Seconded by Dr. Halpern. Thank you. Any further discussion on this?
Yes, time frame.
Time frame. I would say effective now.
Well,
This is the way it
We
has
have
to
6
be.
more months to finish it for next year,
months.
right?
Let's turn around. They're not even here, so potentially.
So January 2014?
Effective 2014. This is the clarification effective in 2014.
Effective with the 2014 turnaround.
Yeah.
Yes.
Yeah. So it won't be required, but should be encouraged for this turnaround document coming.
Excellent. Now, is there a way to actually have a consensus forming conversation through Robert's Rules of Order? Because I'm not really sure where this falls in that whole thing. We should actually, these should all be friendly amendments, I think, to the motion.
Well, you always have, you have your primary legislation, your enabling language, that's different. That's okay. You could just make that motion, pass the motion, and you can decide how you want to enact it.
Okay.
It doesn't require any substantive change in the law.
Jonathan's going to do a filibuster for the next 4 hours.
I like the yellow pages for Queens County, New York. I hereby call Arnold A. Aardvark to the
All in favor? Aye.
Aye.
Any opposed? Excellent.
So I just want to clarify,
The clarity. The clarity.
And you can't clarify.
January 1st, 2014, when the agencies do the 2013 turnaround document, this is not the rule.
They may use either one.
Okay.
They may interpret it either way.
It's for the
Okay.
2014 turnaround document.
Which will be completed in 2015. Okay, understanding.
And that ends the academic committee. Report. Well, you missed that. That's where this all started.
Except for the NIASH piece,
Oh,
new business.
the NIASH, yes.
Shall we skip right to new business and talk about the NIASH survey?
Sure, why don't we do that?
Why don't we do that?
That would be it.
Who would like to talk about the NIASH survey? Rich, do you want to? It was addressed to you.
It was addressed to myself and the Deputy Chief Nerney, who couldn't be with us today. I invited him to try to attend. Skip Nerney and I got an email kind of out of the blue from a PhD at NIOSH. We later found out that Lee Burns had given our name and contact information to him. NIOSH apparently wants to measure the body dimensions, that's their term, not mine, of 82 EMS providers in 8 target cities around the United States. So they reached out. I see the looks already. This is great. They reached out to Skip and me to see if we would be willing to host them. I'm not sure if I have 82 people who would be willing to have their body dimensions measured. So and Skip and I are jointly reaching out to the region, hoping we could do something regionally through Remo and perhaps get 82 people here to volunteer for that. They need space for a trailer, they need a small room to work in, which we have both at this facility, as long as the landlord is agreeable to the trailer. And the people who participate would be paid, it's a 2-part measurement thing. Each one is about 30 minutes, $29 for each session, so a total of $58. The purpose is to reduce injuries to EMS providers and look at the interior design of ambulance patient departments. So if they get all skinny providers, we'll all be sitting in like children's car seats.
That's my concern is there's a research flaw here. I mean, this is not a way to collect your sample population.
Yeah. The problem is that it, some of the intent is, I see this as all the intent is good. The potential for some type of a selection bias is very real in this. It's very real because it's a self-selected population. You know, obviously you'd also get very different things if if one of the rewards was carrots and the other reward was donuts. You'd also get a self-selected population. But at the end of the day, 82 providers from our pool of 700-800 paramedics, and then I don't know what 3,000 EMTs. We've got a pretty good pool to draw from, and frankly, looking at this, all of the federal data protections are in place on this study. I see no harm as I look over the study materials that can befall our providers as all of this stuff ends up stripped of their identifiers other than region. And from there, the agencies that are choosing to participate so far have already said, we don't want any of this information ourselves, so there isn't any harm that'll befall a Mohawk employee for participating in this because of some measurement that's, their BMI is too high or something, or too low. I don't know what the guidelines are. But the one thing that I do really see as benefit is right now when they test an ambulance, they use a standard 75-kilo crash test dummy. And I'm not really convinced that that's providing any useful data for most of our EMS providers. And I'd really like to see as much ergonomic research go into protecting our providers as possible.
You really need to set up at a hospital and just take the next 80 EMS providers that come through.
He's the right way to do it.
The problem is,
He takes a half hour per person.
the problem is it takes half an hour for each segment of this, and if you were to do that when 4 Colony ambulances were down at Memorial, I don't think the town would be very happy that we had no ambulances left in the town.
We're also concerned about the issue of
We're going to take
consent.
a picture of we will tell everything.
Both Skip and I are dealing with a union.
Exactly, it's all got to be off-duty personnel.
I think he's still tied up with court counsel on this in the city of Albany. Not sure if it's,
But certainly off-duty personnel won't be an issue. The only question is whether or not the city endorses the study or it's just endorsed by this body and others. If anybody wants to look at more of the research documentation, we certainly get that information passed around to everybody, everything that Rich has gotten, forward that out so you can take a look at it. But it's certainly an interesting idea, and I would like to support it.
If you wanted to randomize the sample, we could, on a regional level, invite people randomly, and when we get 82 people,
we would have to talk to them as to whether or not that falls into their study design and how they are choosing to select people.
Okay.
You're supposed to get more information from the NIOSH,
Right.
not yet. So I will forward everything along to Dr. Daly as I get it.
So just to move things along, we support in concept. I think the research methodology is flawed. That's not my job to determine here today. So there, I can't wait to hear Jerry Hoffman rip this apart when it gets published.
I believe that is a motion from Dr. Ushkow. Cannot wait to hear Jerry Hoffman rep this apart.
And so you guys are gonna put it up on the website with a sign-up sheet once we get a date, from what I understand.
Yes.
Yeah, and we'll get additional information out to everybody here so you can just read and see what people are gonna do.
See how many people we get?
And for those of us that are still carrying paramedic cards, you can come on, sign up and be part of it too. No?
If you want to email a flyer to the EMS directors at the hospitals, we
That's
can
a good
post
idea,
it
too.
as well in case they're not on the website.
Really good idea. Really good idea. All right, thank you all. We have great news in that there actually are going to be CMAC and SEMSCO meetings in October. We are all very, very excited about that. You will notice that I also sent along to you some information today about changes that are proposed to Article 30 that may be going through the legislature this spring still. So stand by, because the CMAC and SEMSCO may actually not exist come the fall. But if they do exist, there are now scheduled meetings. With that, I would like to propose, at the suggestion of Rich, that if we have the meetings in October, that we plan on skipping the October academic and Remac meetings, because that will be the day of the CMAC meeting. So, what?
I would just suggest we skip the meetings, but for academic, those people get credit for being
I'll leave that entirely to John.
They'll get a free pass, it's kind of like,
Free pass, exactly.
golden pass going.
So that's just a proposal from the chair. Do I have a second for that? So we don't miss people on that. Thank you, Sarah.
Do you want to just have your meeting anyway?
No, we don't want to do that.
Back again.
Well, we can, but then it presents a problem for.
Would we lose a quorum for the bank?
Yeah, you'll miss specific groups of people.
Will we lose a
and-
quorum for the bank?
Yes, it won't be a match.
Yeah,
At all.
probably won't. Anytime we've had meetings that have overlapped with other meetings, it's ended up costing us quorums and lost people who are interested in getting business on the floor. So, all right, all in favor? Thank you. All right, is there anything from the rep, Rich? Sorry, I skipped right by that. Okay. And then I think we are at this point turning the floor over to Dr. Funk, who was nice enough to join us today, for two things. The first is going to be LifeNet's airway program review, which Deb has for us. Do you have that up for her?
Yep.
Okay. And then also to talk about tranexamic acid. Did I pronounce that correctly, Dr. Broder?
Just call it TXA.
TXA, because I'll probably screw up the pronunciation again. And to talk about TXA and the patient care guidelines, not the protocols, as they pertain to LifeNet of New York, because they're patient care guidelines which do not have to be reviewed by anybody, rather than protocols that have to be reviewed and passed by the CMAC.
I
Right?
see, that is correct.
Interesting. Dr. Funk.
Are we on? Thank you for waiting to hear from me this month. What do I point at?
Right click, just right click.
Magic. So I'm sorry that I missed everybody's presentations last month. This is just the requested airway data, and I brought some interesting evidence-based kind of things that we've been working on, and just some of the airway data that we look at, and some of the things that we've learned with our airway data. Every one of our charts goes into a database, the Air Method Medical Application. And this is just one of the sections of all the airway data that we collect. So it's not just the things that I'm presenting today, but we look at a whole bunch of things with all of our airway management calls. The information that you're looking for here, the total number of calls for the time frame that we pulled was nearly 4,000. There were 117 arrests, but those weren't necessarily arrests at the time of intubation. The way that we pull the data is, if the patient had a heart rate of 0 at any point, it pulls that out as an arrest. So those weren't necessarily intubated as an arrest. Our total intubations were 328, the majority of those being seen. Medications were used in just about all of them. Endotracheal tubes were successfully placed in 305, with the King being placed as the ultimate airway management tool in 20. One of the 328 intubations, no, one of the, yes, 328 intubation attempts ended up with a BLS airway, and we'll talk about that as our interesting case of the year. We did a, our quality improvement study last year was to look at scene times, actually. We were questioning whether a 10-minute, the platinum 10 minutes is actually a reasonable goal for everybody pre-hospitally, and we discovered that if you don't do anything for the patient, in fact, our average scene time is 8 minutes. If you actually have to do anything for patients before you begin transport, which in many patients getting in a ground ambulance or in an air ambulance, you have to, that increases the scene time. And for us, it increased the scene time, I think, 3 minutes. If IVs needed to be established for medication administration, it increased the time a predictable 9 minutes if IVs had to be established and RSI intubation had to be initiated. So our mean time for airway scene calls was 17 minutes. I'm not sure how the minimum was 0 minutes. I didn't actually pull that one, but that was pretty darn good, I think. 0 minutes for an intubation on scene.
That's skid to skid?
That's skid to skid, yes. And that's just a graph of our scene times. So just some of the studies that
Can you go back that graph for a second? I'm sorry. I don't mean to be a nuisance, but really, 3 minutes?
What's that? Yeah, I know. I don't.
Okay.
I know. I didn't look at the individual data. I just pulled it.
Okay.
That's pretty good, though, isn't it?
Pretty good. Pretty good. I'd say 9 minutes is really good.
I think so too. 45 minutes isn't, however.
No.
But anyway, since we presented last, we did some pretty interesting, in my opinion, interesting airway studies, and I think I may have discussed with this group some of these. In 2011, we pulled not only New York's airway data, but Northeastern LifeNet, the entire region airway data, and really picked it apart to see how we were doing in terms of first attempt success. What's your first attempt success? What's your second attempt success? And in the olden days, what we used to teach was, if you got in there once and you looked and you didn't see anything, you should go in a second time because you're the most experienced provider in that airway at that point. And we're assuming that both of our providers, the flight nurse and the flight paramedic, are equally experienced and equally able to get an airway. But what we actually discovered was that your best attempt is your first attempt. Our first attempt success was about 75%. The second attempt success was about 40%. So if you miss on your first attempt, your best bet is to turn it over to the next provider, who would then have 75% chance of getting that airway as opposed to your 40% chance. And so we changed our policy to say, if you miss your airway, you miss your endotracheal intubation attempt, you get out of the seat. And you move over and your partner gets in and you prepare the king while they make their attempt. And if that second attempt is unsuccessful, the king goes in and you move. The big difference in this was that we focus on airway management as opposed to endotracheal tube placement. That was huge for us, and I'm sure that that's huge for most intubators. The focus is not on putting plastic between vocal cords, but rather on oxygenation, ventilation, and prevention of aspiration. And so it became such that a king is not a failure. And so people were much more willing to get out of Dodge with a king in place, and we weren't spending 45 minutes on scene necessarily and having like 6 intubation attempts and mucking up airways. So we thought that that was pretty useful. Yes.
So did the percentage of success with the different intubator actually reach 75%? When the first intubator failed, or was it related to airway anatomy and they maybe got to 50 or 60%, but not all the way up to 70%?
It didn't. It was hard to probably know because we only had 20 king placements, at least 20 king placements this past year, and that I don't think has changed. Actually, we're doing more king placements now, so we had even fewer failures back then. So I don't know that we could really tease that out. We did look at we separated it out by provider to see if any individual providers were really stinky. Was it nurses or paramedics? Was it based on how long you'd been in practice? Because at that time we actually had a whole bunch of new providers because we had opened a handful of new bases. And it really didn't matter how long you'd been doing it. It didn't matter whether you were a nurse or a paramedic. You still had about a 70% success rate, 70-75%. And I don't know that we specifically looked at individual airways. We looked at individual providers in their attempts. So, yeah, was there just an airway that was hard?
Just,
and
it's
that's
probably a combination, but it'd be interesting to know if that second attempt with a new provider hit 70% or not.
If it didn't, then it would have skewed, I think, the numbers. We were looking at about 5,000 airways, so it was, you know, big numbers. But what we took from that is our classic teaching and our classic thinking about how you should manage an airway when you have a team was flawed. We figured you just need to get out and switch. And the biggest thing was in getting people to understand that if you didn't walk away from the scene with plastic between vocal cords, you had not failed. If you oxygenated, ventilated, and prevented aspiration, you were a success, no matter how you did that. So in 2012, another of our LifeNet programs in Virginia did a study looking at the bougie use. We've been using bougie as a tube introducer for quite some time, but rarely, and people would only pull it out when the airway looked very anterior or difficult, or when they had failed the first attempt or something. Well, Virginia looked and decided and found, in fairly small numbers, but found that their first attempt success rates were significantly better, I think from 40 to 70% when they used a bougie on that first attempt. And over the course of the study, that success rate improved. So to us, that meant the more experience you get with it, the better you get. And so we changed our airway algorithm to add a bougie for anything that's a Cormac-Lehane grade 2 or higher. So even if you think you would get it, if it's not like the perfect #1 airway, you're to put a bougie in and use that as an introducer. We're still having some trouble with compliance with that. People think that the 2 is easy, they're just going to do it. But the point is we want them to get the experience with the bougie. So this is something that we're working on right now. And we're continuing to look at our airway success rates, our practice, and ways to improve efficiency and quality of care by just collecting all of the data within TAMA. And right now what we're following is this bougie use. And hopefully we can get some significant numbers and see if, in fact, use of the bougie in certain circumstances will improve our first attempt success. So that's what we're working on. Okay, problem case. Our one true failed airway happened actually just before I was asked to pull this data, so it was handy that we had one just in case to talk about. This was a motorcycle accident who had some significant chest trauma and was unable to lie down or permit any care to be done because of the amount of discomfort and shortness of breath that he was having. So the crew chose to RSI intubate him. They provided him with pain control and then gave etomidate and rocuronium. There were 2 intubation attempts actually by the same provider because after he finished his first intubation attempt and was unable to see cords or pass the tube, the patient became hypoxic and he was unable to bag valve ventilate. And so rather than take the time to get out of the seat and the other provider get in the seat, he made a second attempt while that other provider was getting the king out. The second attempt failed. They put the king in, it failed. The patient went into arrest. And they went into the closest ground hospital, which was actually just a couple of minutes away, with a BLS airway that was largely unsuccessful at providing oxygenation. The hospital, after some time, was able to intubate the patient, resuscitated him, and that same crew was then able to transport him to the trauma center. The outcome was not good. We reviewed the case extensively immediately after with the ground providers, with the receiving docs at both the initial community hospital and the trauma center, and then we discussed it in a program-wide CQI, which actually went really, really well. Our providers that managed that airway came to the group and had really gone over the case in detail, both as a team and with everybody that they had interacted with who had taken care of this patient. And the bottom line, what we learned as a program from that, is that we've spent so much time drilling on you know, who gets the first attempt, who gets the second attempt, and where the bougie goes, that we kind of, not that we forgot, we have protocols for surgical cricothyrotomy, but that wasn't part of the muscle memory. The muscle memory was give the etomidate, consider giving the paralytic, put your endotracheal tube in. If that failed, give it to your partner. If that failed, put the king in and get in the aircraft and go. And that next step wasn't drilled into muscle memory. And so we assumed it would be, I guess, such a rare event that we didn't necessarily have to practice it every time we practice airways. But in fact, that's wrong. And so actually this month we are redoing our airway algorithm to reflect that, and all of our airway training now is going to go through the entire step or the entire process. And every provider is going to be doing crics with every airway practice session that they have, and they're going to get pretty darn tired of it, but we're not going to have this case again. So I think that is what I have. Any questions?
I have one more question.
Yeah.
It brings up an interesting point. So here's a community hospital that gets a patient who's been paralyzed, had 2 failed endotracheal intubations, and a failed king, and they don't go immediately to a cric.
That was part of the discussion.
It's an interesting thought, because typically if you haven't failed yourself, you haven't failed, right? But I guess I wonder whether there's a teaching point around that whole issue as well, in terms of, for the community hospitals, whether they should start back at step A and try to endotracheally intubate this patient, or now they've arrested, they've been down, should they have just...
I can tell you they were not successful in intubating the patient the traditional way. That was one of our crew's issues, is they assumed that the best plan for the patient was going to be going into the hospital, which was, I mean, right there.
Yeah.
And from my perspective, that was a great plan.
Sure.
You know, had they stayed out in the ambulance, they would have gotten to the next step and would have done the surgical cric, but they felt they had an unmanaged airway and there was a hospital that they could see. So they went there. This is an area that we are new to practicing in. They don't know us terribly well. And so I think, you know, from my standpoint, when a provider who has failed an airway comes in, I'm asking them what they did. Tell me, what did you do? What did you see? What did you try? And I'm not going to do the same thing that they did, because, like you said, that seems silly. I would like to start beyond that. Go ahead.
I think it'd be an opportunity to drill with community providers. It doesn't happen very often, but I mean the community EDs, because you probably shouldn't start back at the beginning, but yet if we don't have that conversation ahead of time, and we're not comfortable picking up where you guys left off, we waste a lot of time sometimes.
I think it may depend on who, you know, who the provider is and what your comfort level with that provider is. And it's, I mean, those of us who accept patients in this situation, you know pretty quickly what the confidence level in that provider is and what their experience is. The nurse on this flight was new. The paramedic has been working for as long as I have. So he could intubate me any day, frankly. So the fact that he was unsuccessful at this airway was a little scary to me. And he was disappointed. And we have met with that hospital staff, and gone over all of these issues. So, yeah.
Have any thought of glide scopes for you guys?
Yeah. Our thought on additional tools is that we need to be really good at what we have, and the more tools that you have, the more dilute your skills will potentially become. Air Methods is trialing 3 different video laryngoscopes. I'm not sure which ones they are. Our Cobalt base is the New York base that's trialing one. It's going to be a company decision because they're not cheap and we have a lot of aircraft out there. But they're going to make some decisions on the clinical side, company-wide, and probably give us something. But we've hesitated to really start pulling in all kinds of fancy tools. We figure if we are nearly 100% successful in managing our airways with what we have, why do we want to dilute that with something else? But it's something we've talked about.
Don, it's interesting from that. Hudson Valley is in the process of doing a critical care EMT course. It's a course out of UMBC, and I did a cadaver lab with them. We had 4 different cadavers that we rotated all of the providers through, doing a whole bunch of just standard airway management with some basic skills. We had a King Vision, which is one example of a video laryngoscope with the camera and the scope on the handle. We also had the glide scope, the standard glide scope that we would use down in the emergency department. And the providers actually split 50-50 on who preferred which one. And there were actually some of the cadavers that were better suited to one style of the sweep of the blade than the other. It was kind of interesting. It was very interesting to see.
The
I'd
big
never
difference in
gotten
those
hit.
devices is really the provider's position. I mean, they're both excellent devices. They both provide great field of view. But if you're in a situation like a confined space like yours, maybe your ability to get yourself parked over the top of that king vision, like you have to do with that, isn't always there. Versus the glide scope gives you some offset capability where you can be literally like this. I'm just saying.
Yeah, and the other
think
side of
there's no
that
silver
too,
bullet.
and Nash,
Yeah,
actually,
no.
you've got the glide scope up in Wilton, don't you? You know, the problem there is then where do you put the screen? That can sometimes be something, be a drill with it. I'm sure you can figure out ways to do that.
Was this patient that was problematic? Did they have bad body habits?
No, nothing. Because part of our documentation is assessing the predicted difficulty, and he was not a predicted difficult airway.
Interesting.
Yeah, which is why they chose to give him rocuronium as opposed to having the issues associated with sex.
Which
Cool.
is actually
What
one
I think-
more of those reasons that you'd think, okay, if for some reason these cords you just can't plain get there, can't see them, that's they're faster to the neck.
Yeah, they never saw
Yeah.
cords at
So what
all.
was the reason they didn't give sucks? Because they just thought it was doing a good innovation, and they thought they could put the rock on board and.
We tend to steer away from the sucks if you think that the rock is a better option, because this patient was going to need long-term paralysis.
Sure.
And the sucks has so many more complications or potential complications, so they felt that this patient was not a predicted difficult airway. And I know as
Sure.
soon as you say this won't be a problem, that's when it
Yeah, I mean, we have the
loose.
luxury of time here. We're money board
Yeah.
quarterbacking, you know, we're just wondering.
Yeah, so this particular provider, since we added the rock, has used it and really likes the way it handles. And so he's chosen to use it on the majority of his airways. The other practice that we have is before you give somebody a paralytic, you put a mask on their face and make sure it seals. And this patient had a seal. So there was something in his lower airway that prevented them from getting in and prevented them from being able to adequately ventilate him. And the king didn't work either, so there was something in his lower airway. And it would have been nice for us to actually know what that was, but the medical examiner wasn't able to provide us with that information.
There's two things, Beth. Just, I know you're worried about skill dilution. There are two companies. GlideScope is catching up, and Remac has the exact same shape and curve as laryngoscopes. That way there is no skill dilution. You can either do the option of standard intubation or use the video laryngoscopy with no alteration or loss of skill, unlike if you use the standard GlideScope, which has a different curvature.
Completely different procedure,
So
right.
I just throw that out there.
Yeah.
I'm not trying to sell any particular
Unfortunately,
scope.
that decision is a little bit out of my hands.
I know.
Because of the cost involved, the company's making that decision at the corporate level.
And the other thing is, do you know if this guy had a broken neck?
He did not have symptoms of such. His complaints were all chest, and the information that we got from the medical examiner did not give us any answers about why his airway was so difficult.
Okay, just curious.
Yeah.
Sarah, you had something?
Just, of all the patients I've had brought into the ER that EMS was unable to intubate, I've never had to correct one of them. They've all been, I've been able to
This guy
intubate
looked
either in
easy
the
from the
traditional
outside.
way or with a glide scope.
Right.
But I've never had to just take off where the paramedic left off. I mean, there's probably a handful of paramedics in this region that if they brought me a patient and said they couldn't intubate it, I'd just cripe them.
Yeah.
But for the most part, I've been able to intubate every single one of those. So I
agree.
I would hesitate to recommend not
Going right
starting
to
at the
the
beginning. But I mean, your guys are obviously different. They do a hell of a lot more intubations than the average.
You have a bad day, though.
Yeah,
You know,
absolutely.
Anything's
Absolutely.
possible, right. So I agree with you. I've had providers come in and we ask, and when they have been, sometimes they give you very useful information about what they do, what they didn't do, allowing you then to pick something different. You know, they say, I used a 3-Mac, I couldn't get anything, and then the patient decompensated, so I just threw in a king. Okay, I'm gonna get a 4-Mac. So, now, thank you for that information. So I typically take a look. And who takes that look depends on who the paramedic was that delivered the patient. Is it the intern or is it me? That's the information, that's how I use the information from the providers in the field. So I think if one of my flight providers came in unable to intubate the patient, I really might call anesthesia, actually. Because I've learned my lesson and I'm not
We
very
did not think it was
I know.
But community hospital setting is different. I mean,
It
you know,
is.
Most of these folks work in, depending on your definition of community hospital, There's big ones and there's small ones.
This is a small community
If it's a
hospital.
small one, it may not even be an MD intubator.
This was,
Small enough.
there were 2 MDs and they called anesthesia and anesthesia intubated
So
patients.
they have anesthesia available to do it.
So it was not that small? Yeah.
It's not that small.
Not that small.
But the other
So-
thing is, that northern area, there's a lot of open docs of the ERs. And we get complaints constantly from providers, but they don't listen to us or they don't know what we're capable
Right.
of. So it could have been a shared, I don't want to say shared fault, but there was a fault
Yeah,
in the
they don't,
system.
through this, we discovered that they don't really know us. And so we're working on fixing that. So we were invited to come and speak with their staff and we did that. And so it's turned into something that'll be good for us because we're new to that area and we're gonna go and do some training with them and everything. So it'll be good. And I think, we all learned. And the important thing is we, as a program, we looked at it not as a failure of a provider, because truthfully, I would let this man intubate her any day. Especially when she's got a mouth on her. I would like rocuronium. No. And I forget where I was going with that.
CPS, I think.
Jail. Forget it. No, what we did was we didn't hang him. We looked at the system and how it was that the system could have failed him. How did the system fail our team? And our CQI process is such that people are very willing to come forward and say, I messed up and I'm not sure how that happened. And so that we can then go and look at the system and figure out how did that happen. So we didn't hang him at all. As a matter of fact, his peers, we had about 50 of our 85 providers present at this big CQI meeting. They gave him a standing ovation for being willing to come forward and talk about this case in such detail and how he handled it afterwards. That it turned out to be a good experience for him to get some closure on the whole, failed airway thing too. So I think we all learned a lot from what turned out to be a pretty difficult case. And I think it's an important part of the CQI process not to hang an individual. You gotta look at what caused or had, what led to a situation that could have led to that problem. Not that anything caused this problem, this could have happened to any one of us. And that was really important to know, but he was willing and interested in coming forward and helping us prevent this from ever happening again to anybody else in the program. Any other questions, comments? Thank you. Thanks for letting me wait till this month to come. Shall we transition to TXA?
TXA.
So Albany Medical Center has initiated a protocol to use TXA in trauma patients that present with hemodynamic instability, looking like they're going to need blood, and don't have contraindications if they present within 3 hours of the traumatic event. They approached, the trauma folks at Albany Med approached LifeNet to consider adding it for those patients that were that qualified and were coming back to Albany Med, whether we picked them up at the scene or in another facility, if they fell within that 3 hour time frame. And we put it together and figured that would be really great. We queried the trauma centers across New York State to see, should we just give it to the patients going to Albany or should we put it on all our patients? And so we called all the trauma centers and said, are you using TXA? And most of them said, excuse me? And then they said, wait a minute, we'll get back to you. And since that, many of them have started to develop protocols. Some of them don't want to, but what we've decided to do is rather than try and ask the providers to figure out where they're taking the patient and based on where they're taking them, give them a different level of care, we've decided to put it into our patient care guidelines for trauma victims that we get to within 3 hours who are 18 years of age or greater and do not have contraindications. If they present with hemodynamic instability after a traumatic incident, we would like to begin the loading dose or give the loading dose, and then if we wind up with time, start the maintenance dose in accordance with Albany Medical Center's protocol. So that's what we emailed that out, and I do have a paper copy if anybody wants to look at it. We did make a slight change to it after some of our other medical directors looked at it. The initial thing that I sent out spelled tranexamic acid incorrectly, and the age criteria was unclear. It said greater than 18, but the intention was 18 or greater. It's for adults. So
I'd like to point out that the official Remac pharmacist picked up that error. So, well done, Dr. Crowder.
I just looked at it right before the meeting. I'm sorry.
Okay.
I was trying to keep it subtle by
David,
just
I
telling
know.
Mike and we could fix it as
David
opposed to making
Stuhler.
it a big deal.
David Stuhler, one of our other
All you
directors,
just
emailed me last
you
night.
added an S, and a lot of people, and I know
A lot of
myself
people
pronounce
do.
it like transaximic. It's
Right.
transaximic. That's why we call it TXA.
Right. It's fixed in the in our original.
Is there any obvious contraindication to the drug other than allergy, of course, but
Allergy to
what
the
about
drug.
people who, with thromboembolic disease who are traumatized?
Known thromboembolic disease is one of our contraindications. Albany Med has asked that we leave it somewhat easy to give the drug because the studies that identify the contraindications, as I understand it, are not, it doesn't seem to be contraindicated. It doesn't seem to cause harm in many people, if any people. If you go within that 3 hours after a traumatic injury. So when I started to say, well, what's that mean? Does that mean anybody who's on anticoagulation? Does that mean anybody who says they may have had a DVT after they had a broken leg? What does that mean? And they said, just say known thromboembolic disease. They don't want to get into more detail because they want people to be able to get the drug when they qualify for it. So it's a very short list of contraindications.
Do you want to read that list off?
The contraindications are greater than 3 hours from the time of injury, active intravascular clotting, known thromboembolic disease, DIC, and known sensitivity to tranexamic acid. So we would like to add this to our formulary and add this patient care guideline to our patient care guidelines.
It's not on back order yet?
No.
Not yet. And it's still cheap too.
We have it at.
And it's still cheap.
It's $50 a vial. It's not as cheap as we thought it was going to be.
50?
50.
They added the zero when they
11
found out people
aircraft,
might want it.
I was told it was $16, but that's okay.
That's I would agree with Bruce's number.
No, we got a number
Okay.
from Albany Men's Pharmacy too, and they get it for $48. So McKesson selling it
They
to
don't
us for
shop well.
$58 is fair. I know we thought it was going to be pennies.
Yeah.
As
It's
it-
a helicopter flight, that costs what?
Don't go there.
A little more.
Just saying, just saying.
Don't go there. Somehow it doesn't
Yourself a snit over the
equate.
fence.
Somehow it doesn't equate. That money doesn't go to buy the medicine for the helicopter, trust me.
Any other discussion? I'll take that as a self-directed motion from Deb. Second? All in favor?
Who seconded?
Thank you.
Dr. Vogel.
And we're going to actually work with Albany Med to study the changes that we see in statewide practice based upon our initiating the drug to see if maybe, like maybe some other interventions that we've done pre-hospitally, like capnography and King and 12-DKG, I don't know.
Opioid use.
Things like that, to see
Yeah.
if we can actually impact in-hospital change by doing things pre-hospitally. We're going to study that. We'll see. And that is my LifeNet stuff. If we're under new business, I have something else.
Deb's only going to come once in a while. She's going to take an entire afternoon.
That's very nice.
Quick timeout for a quick mustache review.
I'm glad I could bring your entertainment for the day. Can I keep
Would you
going?
like to talk about?
Yes. I'm going to switch hats. Mohawk Ambulance. We have enjoyed a significant amount of success, at least from my perspective, with our specialty care program. We came to this group a while back about identifying a handful of our providers to train them up to a higher level and allow them to do interfacility transports that involve more complicated medications and interventions. And this group has stepped up amazingly. We've got another 4 providers in the pipeline going through the CCEMTP class right now, and we've got a lot of really good things going on. We're doing CQI, they're initiating their own education, and they're asking me to expand the protocols, which is kind of exciting. We will be coming, we're going to put together a plan for MFI so that we can maintain paralytics if necessary and appropriately manage airways as we're transporting some of these really sick patients pretty significant distances in some cases. But that's not for today. Today is super easy. We're noticing that some of the patients that we're being asked to move are on drugs whose classes we've been approved for, I don't know, we were approved to carry and maintain Cardine. Now people are using Clevaprex. It's another calcium channel blocker, but we were specifically approved to use Cardine. Another is, let's see, well, Angiomax and other anticoagulants. The hospitals are changing the drugs that they're using, and it's a simple matter of looking it up in a formulary or making a phone call and being sure that it is in fact, you know, part of the same class. What we would like is we would like for our medications to be approved as classes as opposed to individual drugs.
We've actually done this before, but only with an individual class of drugs.
Right.
Remember, we did this actually when Angiomax was Ellis's new preferred anticoagulant or antiplatelet agent. So we'll be best off to just look at this, expanding this across all of the interfacility drugs.
So my request is, and I've listed them all out, but it's essentially the classes of drugs that we've been approved to manage. We'd like to manage them as a class, as opposed to just an individual drug. And while esmolol and labetalol are the only beta blockers that we see right now, who knows what's going to happen next week? So we would like to be approved for beta blockers. And of course, if this is mandating that the provider have some sort of written reference in front of them for that individual drug, if they're going to manage it. So if they encounter a drug that they don't have in our formulary on their tablet right in front of them, they are to use a reference, get it, and review it and be sure that they're comfortable with it before they move it, because not all calcium channel blockers are the same and all that. The other drug that, so that's number 1 is, can we be approved to use classes? Okay. Number 1, can we be approved to manage classes as opposed to individual drug?
Commentary from pharmacy?
I mean, it seems very reasonable. I guess when you talk about anticoagulants, it's a pretty broad stroke, so you want to probably drill down to the different ones there. But like, you know, for example, PPIs, who really cares if it's Protonex or another PPI hanging there. Calcium channel blockers, again, as long as, you know, you're specifying whether it's a non-dihydropyridine versus dihydropyridine, that's reasonable, I think.
How about if I give you my list and you tell me how to classify them?
Sure.
Will that work?
Perfect.
To make sure that we're, because truly, like I said, not all calcium channel blockers are equal. And I mean, Cardine and Clevaprex are pretty different, but we use them in the same types of patients, and it's just a matter of knowing the different indications and the different doses. So I can get you, I'll get you our list and what my thoughts were, and you can tell me how to make it more appropriate.
So are you suggesting a protocol change specific to the IFT protocol, or?
Well, all these drugs are IFT, the drugs that I'm looking for. Because we're not carrying any of them, we're taking them on direct
this is all on your interfacility transport protocol. The only one we changed in the IFT program is we changed our interpretation of anticoagulants from just to any of the anticoagulants that were currently being used as drips when Angiomax came on. And that was the way we interpreted it here.
Well, what I kind of recall in the past is that any medical director can authorize any specific.
With approval here.
But the approval was designated to come here. So
rather than every time somebody comes up with a new calcium channel blocker, I have to wait till the next time I can come to a meeting to get it approved.
No, you can do whatever.
I want to just be able to tell the crew, yes, do it.
But you didn't have to come.
Right, so we'll never see it.
My impression,
The-
my impression was I had to
The,
come
the
here.
interfacility thing becomes an interesting question.
Yeah.
Here, we've generally tended to maintain a larger group of physicians providing oversight to the interfacility program that our commercial agencies are doing, which generally our commercial agencies seem to have appreciated just that additional insight into what potential complications there might be. It seems to have worked reasonably well. I have no doubt that Norm is now going to take this back and relook at how Greenport does theirs. You know, it just offers a better opportunity for people to talk about how these programs can work. Frankly, these are Article 28 facilities that are shipping patients between one and another. This is a black hole of regulation rather than anything else. This is something that we've chosen to do internally to provide an additional layer of safety for everybody. Interesting, in the collaborative protocol process, the interfacility page is the only page that's really caused any agencies to get upset as they've reviewed our protocols. Because they say, well, you know, we do this all the time, we're okay, we don't need any rules. Well, I think some rules, some structure, sharing experiences, I think is pretty important. Pretty important, and the rules is really important.
I guess the other thought too is how much work would it be just to make your formula that much better? I mean, so I remember helping you guys out, had some comments a few years ago, but just to expand it, and as new things come out, we just keep on growing and growing that. So
And we
therefore
will.
you have,
When we see a new drug, we'll
Right.
make a new formulary entry and stick it in there. It's for the time when the dispatcher calls me and
Got
says,
it.
hey, they have a patient on a tranexamic acid or whatever
right.
drip, can we manage
substance,
that?
whatever, substance.
And I can
right.
say, yes, have the crew call me, because it's within that class, and I'll make sure that they have the appropriate, you know, they can look up in Hippocrates.
Right.
Or I can send them something, and so that they can have a reference right there. And then that crew will then produce the formulary entry that we can stick right in our formulary. Called COCQL.
Very cool. Bruce, from a critical care perspective, anything else?
No, I'm happy. The only question I have, which is just for my own interest, I noticed in your original presentation that you actually intubated people interfacility transfer.
Oh, yeah.
I question, why did that happen? To me, that's a physician error, the sending physician's error. Why weren't they intubated ahead of time? I mean, did they really
Many
crash all of a
times.
sudden? or-
Yeah, it's interesting because your thought was the same thought as many people sitting around the table at the Cmac when we pointed out that paramedics do have to practice in hospitals. And that's because many of the hospitals that we go to are not comfortable managing some of these patients and doing these advanced skills. It is very common for us to hear as we're coming into the hospital, we're waiting for you to manage this patient's airway. We're waiting for you to place an IV. There are some hospitals that they just don't see kids or complicated patients or whatever, or they have a difference of opinion. That patient who's sitting in their ED didn't need to be intubated, but that patient who's gonna get in the aircraft for 45 minutes in a tight space was likely to decompensate, and so we determined needed to be intubated. We intubate people that sometimes don't need to be intubated sitting in the hospital, but they do for transport.
So you don't wheel them out in the parking lot
And intubate them there.
to
Right.
secure the regulatory requirement. that you're
Exactly.
not inside.
Exactly. And that is some people's suggestion.
No, I
And
would like
that's
to
wrong.
point out, any of these patients who are intubated inside Article 28 facilities, in order to be in keeping with the Department of Education guidelines, were all intubated by the flight nurse, not the flight paramedic. Right? Yeah, there we go. Okay, good. All right, got it. Let's not go down that rabbit hole.
I'm not allowed to say that nurses intubate anyway, so. The nurse is assisting the paramedic.
The nurse is assisting the paramedic with the skill, and the paramedic is being assisted by the nurse with the authority.
The nurse is licensed, the paramedic's hands, whatever.
Like I
So
said,
how
the
about those
patient sucks the
Yankees?
tube in and call it done.
The patient intubated themselves.
So I can tell you that intubation is not the only skill that we provide inside a hospital.
All right, that answered my question. That just really struck me as a large number.
Yeah.
It scared me.
And many people don't get that. But, I mean, there's very small hospitals that are managed by providers who are wonderful at doing what they're doing, but don't see a lot of critical patients.
They're probably better in your crew's hands
Our
than anyone
crews take care of
at
super
that
sick people every
hospital at
day.
that time.
Yeah.
That's what they do.
Yep.
Interfacility transport is a huge area of hazard. It's a huge area of hazard. And frankly, I'm really glad you guys are out there doing it.
Me too.
Really glad.
So did we have a motion for Deb's
To say classes,
classes?
and I'm gonna get the specific.
Is there a
we're gonna-
second for
we're gonna
classes
clarify
and
the
Deb to
specifics.
continue to work with Mike and then to share the information with other members of Remac as interested?
Sounds reasonable.
Okay.
As long
All
as
in
you promise
favor?
to come back again.
All in favor?
All right.
Excellent. One last thing that Deb wanted to talk about was drugs through
Yeah.
alternative delivery devices.
I did.
You did. Albuterol not being nebulized.
Right, albuterol by puffer on a ventilated patient. Which is better? Nebulize it into a ventilator
Why not?
or puff it?
Puff it in.
Exactly. And so we don't have puffers on our formulary. And so we would like to use puffers on intubated patients as opposed to nebulizers, because in the hospital they use puffers, and so from my standpoint, it must be better. So we would like to deliver albuterol and Atrovent by puffer
The
on
one
intubated
thing
patients.
that I would say about that, and we're thinking about it a little bit beforehand, was if we are going to use puffers, let's restrict that to only albuterol and not ipratropium, because of the potential for the
Does that
less
still
than.
exist?
Although that's supposedly
that's
is
gonna
being
go
phased
away.
out, but it's
gonna be
not.
phased out when it goes from a CFC inhaler to this new inhaler.
Yeah.
So there's still, they have to use up the supply. So what Mike is talking about is for folks who have a true peanut allergy due to one of the excipients in ipratropium and Combivent, there can be some anaphylaxis there, but that is going to go away. When, I can't exactly tell you because they have to use up all the supply. So
But
So
since
for
there
now,
is
albuterol only
that
by
questionable
MDI.
benefit from the
Hmm?
Atrovent anyway.
right,
let's
so
go
just
with
do
the
albuterol then. I have no idea what you're saying.
Hey, Mike, equivalent dose, I thought years ago when they tried doing that study, they needed a number of puffs.
It's like 4 to 1, I would say.
4 to 1.
Thank you for interpreting.
That's what I just
Thank you
kinda
for
reviewed
interpreting. I
about
didn't know what you was
earlier.
doing.
The other thing I'd just like to add to that is, since this is a drug that's already on our formulary, I would say that people should be able to use it in its use if they're in another situation where it might be of benefit. And I say that for something like a tactical paramedic in a tactical environment or in an austere environment to be able to use an albuterol puffer when an oxygen tank might not be the most opportune thing to have more. I'd like to add that in. Because it's a drug that our providers know how to use. It's not rocket science to learn how to use it. It's something that may provide significant benefit and very little potential for harm. And it would be at a time where you otherwise would not have the potential to use the drug, because you would not be able to have an oxygen tank.
Oh, we utilized MDIs here years ago, back in 1986.
There's no wrong.
And Charlotte, that was Greer Power, I think she had brought spacers and MDIs on board.
Okay. Whatever.
Everything that's new is old again, or is that how it is?
Say what the tactical spacing device is going to look like. It'd be awesome, like a
Oh,
black, a black arrow chamber
Oh,
that
yeah.
collapses.
Oh, yeah.
But it won't whistle. But it won't, exactly.
You can't
So it's
whistle.
That would
Right.
divulge
Pocket
your.
right here.
And it'll cost $50 more. Second? All in favor? MDI is good. There's the motion.
I have one more drug. I'm sorry. Diuretics are not included on our regional list, and we've been asked to transport a number of patients recently on a Remac infusion. They didn't want to shut it off. I don't know. So I would.
Diuretics are indeed on the regional formulary.
Are they?
Yes, Lasix is still on our regional formulary.
As an infusion?
Not as an infusion, but we
So-
have other drugs that we then administer as
Good.
infusions that are on there, that would be reasonable to add to
Done.
the list that you're going to talk to Dr.
Forget I
Fowler
said
about.
anything.
Okay?
Erasing.
Yeah. What?
Of the classification.
Yeah, it's even classification. Well within the nature of what we're doing. Any other new business?
That's fine.
Any other old business?
Do you need to adjourn for July?
Thank you very much, Jeff. You have a motion to cancel July. May I have a motion from a member? Thank you. July and August. Thank
Good
you.
motion.
When did you say
Second.
we were going to cancel for?
October.
So we'll have a meeting.
We'll have a meeting in September.
Okay.
At September's meeting, one of the things that we will look at is the differences between advanced EMTs and intermediate EMTs, and what that's gonna mean for the protocols that we're gonna have to be working on for 2014. And one of our goals to look forward to will be a set of collaborative protocols moving forward that should be sent to the CMAC for the spring 2014 meeting for implementation, say June of 2014.
Spring, or is you've got meetings scheduled in October and January?
October and January is scheduled at this point.
In which case, we should probably get it ready for January, but that schedule will not work. Will not work. On the other hand, we may have a quorum in ourselves at this point through the members of the collaborative protocol. We can't have a meeting outside. Is that something?
Can I ask that we, as a region and maybe as a collaborative group, bring to the CMAC the fact that blood is a necessary intervention during interfacility transfer, and we would very much like to see that
Not if you
move.
give TXA.
Not true, you just need less blood.
TSA, HGB, whatever.
That's what my specialty care paramedics asked me to come for, is blood.
I've had opportunity to be able to make comment to that several times. It has fallen on deaf ears. So we will continue to.
We're giving a lot of nurses experience at buckling into the back of ambulances.
They like it, they get to get out of the ER or wherever, get coffee time.
Debbie, if the referring institution has started an infusion of blood,
They need to
No.
send a nurse along.
they can't, you guys
No.
can't
No.
finish it,
No.
even if half the
No.
unit is.
No,
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 matter of fact, you have to take the tubing
no,
down.
hang on a second. Which hat are you wearing? The aircraft can?
No, a paramedic can't.
The
The
ambulance
nurse on the aircraft can.
Gotcha.
Actually, one of our aircraft actually carries 2 units of O-negative blood. But the paramedic's hands should not be touching it.
Yep, I got you.
Right. So actually, calling an aircraft to give blood is one of the indications.
So basically, the nurses are turning into pack mules. We got the narcotics, blood. ET tube.
Exactly. Exactly.
It used to be the paramedics that got to carry that.
I can say this because Carol's out of the room and can't smack me for it.
Shock bag.
It's all right. You can watch it on tape later.
Nope. Never
Right on
fails.
cue. And what'd you say?
Anything else, anybody? Motion to adjourn.
So we are canceling July, August?
We are canceling July and August. Sorry, the motion to adjourn included the motion to not have July and August. I will never be a sergeant at arms.